Okay, shall we start? I will briefly introduce Dr. Suresh in Japanese. Suresh Munuswamy さんはかつて日本に住んでおられまして、東京医科歯科大学 TMD、東京メディカル・デンタル・ユニバーシティ・グラジュエット・スチューデントで、その時に私のプログラム2008年ぐらいから参加されまして、第1番目はインドビジネスセミナーという時に学生としてご参加いただきまして、2010年からはこのブランドデザインプログラム、これを当初慶応大学で行って、渡辺先生と一緒に行っておりましたけれども、その時から参加されていて、そしてその時に最初の2年間で、この今からお話しされるインドのリモートメディスンですね、リモートヘルスの研究をプロトタイプでなされて、そしてそれに変えられてから、インドに変えられてから、このプログラムを実施されてちょうど10年ぐらいになるということで、非常にこのプログラム、着実に、成功されておりまして、今どういう状況になっているかということをお伺いいたします。Dr. Suresh, I would introduce in Japanese, so please continue your self-introductions and your presentation of Hirapid project. Please start.
Thank you, Professor. Well, thank you everyone for the opportunity of the presentation. I would also like to thank Professor Sasara and Professor Hara, who met previously and have also helped me in this presentation. Our focus has been on primary healthcare, and even the previous presentation by Melody also focuses on primary healthcare, where the challenges of lack of skills and the reality that measurement, if it is done closer to the patient, would actually be helpful has been fairly established. One of the challenges with regard to primary healthcare, especially in a country like India, is that it is not accessible. We have only one primary healthcare per 150 square kilometers, which basically means if a person has to reach out and then get the care, he or she should probably maybe travel like at least half a day, and that's fairly common in a country like India. The second issue is the fact that the primary care itself is not really effective, and that's because only a few conditions are actually addressed. And some of these are also not really kind of used by several people, and because of that, the healthcare itself largely is ineffective. And the last part of it is the government is actually spending a lot of money on primary healthcare. It is not being used by people because it is fairly very difficult to access these facilities. So if you want to summarize the primary healthcare in India and in several developing countries, it is inaccessible, it is not effective, and it is also not very efficient because it is actually costing a lot. So what we basically thought was, now instead of actually asking these people to come to primary healthcare facilities which are not being used properly, you need to maybe take this primary healthcare to the person's doorstep. So that way we should be able to provide universal healthcare. And if we are going to take primary healthcare to a person's home, then we need to look at several conditions. It cannot be only for maternal and child care, or it cannot be only for, like, let's say diabetes or perhaps hypertension. So we need to look at it in a much more comprehensive way. And also we need to provide real-time service. So measuring data alone cannot be primary healthcare. You need to start giving interventions also. So these are some of the challenges that we thought we should start addressing if we have to address the challenges of primary healthcare. So we came out with a solution that accompanies or probably includes all these things. And this is how it actually looks like. I'll show you a video and then I'll explain the solution that we have actually developed. Give me a second. I'll shift to the video, please. Okay.
Suresh?
Yes.
Suresh? No
Yes.
sound comes out from here. So you don't have any narration on this movie? Just a silent?
There's only background music, and I'll probably explain this.
Nothing hard.
Okay.
If no narration, Can you narrate a little bit on each part?
Yes,
How do
yes,
we
sure.
see this? Is this a drone delivery?
Yes, that's right. Probably after this video, I'll quickly go through each segment and then do a quick narration.
Okay.
Well, thank you for watching the presentation, but I believe since the audio was not there, or perhaps only background music was there, I will quickly explain what this video is. As I mentioned, the primary healthcare situation in India and most developed countries is not that great. And there is only one primary healthcare per 10,000 households. And it is also very inaccessible. And a lot of people actually do not visit the primary healthcare center. So to summarize, it is inaccessible, it's not adequate, and it's also inefficient. So what we are proposing is, let's deliver the primary healthcare services at home. And when you say primary healthcare, it is not one single service. So if you'd want to take it home, one of the biggest challenges in a country like India is language itself, where if you'd want to do screening for any diseases, medicine is taught in English, but it is actually practiced in a local language or a regional language. Is the audio audible?
Yes.
Please
Now,
restart.
a short intermission came up.
Yes, I went just through a power cut, so I was just confirming. So what we actually developed was, we came out with a solution that does not have language for screening. Primarily, the entire software is icon and image based. So as you see here, we basically, even for something as simple as registering a house, we take images and we have built algorithms that will automatically grade the type of house. And this is actually done in a very short time of 20 to 30 seconds. So this way, we actually are moving from language to icons and images, and also using AI to automatically grade the images that are actually coming in. The second vertical that we are looking at is water, sanitation, and hygiene, where we are taking more images, at least half a dozen, to understand what is the living situation with regard to communicable diseases. So again, here, we are actually taking a few images and grading them and attaching them to the appropriate interventions, as we see here with regard to nutrition. So the third vertical is the nutrition part of it. So we are imaging people and then identifying the grade as in undernourished, normal, or obese, and then identifying what interventions can be given to them. And these are being done in real time. So this is actually populated in real time and shown to them as small video segments. And the fourth part is the disability management. So again, this is being done using screening, using images and icons. Automated interventions are actually being shown to them. And the fifth vertical is basically the disease management. So again, we are using images and icons and identifying the type of disease and the grade of the disease, and also showing the appropriate interventions. So this is the software platform that we have developed. But when we talk about disease management, it also includes not only screening, but also provision of medicines, or perhaps collecting blood or any other sample for diagnostics, which means a product is also involved. So we have developed a two-wheeler platform which has a temperature controlled boxes, because that is again something that is unique to healthcare, where if you are collecting blood or providing vaccines, we need to protect them with regard to the temperature. So we have come out with modular boxes which are standardized to a point that they can actually carry multiple payloads. So the same box, you can use it for multiple payload. And then you can use the same two-wheeler platform to transport medicines or collect blood samples or even deliver vaccines at home. And we are actually using the same boxes to even carry the medical products as in the diagnostic products. And that's why one of the questions I was asking the presentation from Melody International is, can we use those devices at home? So we are positioning this as a platform to use the screening devices also at home. And in places where the two-wheeler cannot actually reach, or when we collect blood and when we have to send it to the nearby diagnostic facility, which again could be at least 50 or 100 kilometers away, we are using the drones, where the same boxes that are being used in the two-wheeler are also being used in the drones. So there is cross-platform mobility here, which basically means the location language is being addressed in this solution here. So I'll go back to the presentation and continue the conversation here. Just a second, please. So this is how the working model actually looks like. So on one side, as I said, you have the input data, which does not have language or any text in it. It has only icons. So the healthcare worker on the field basically looks at the icons and then hits the plus or minus button. And to reduce the number of questions, we have also come out with image-based screening. So again, you take image and then you start grading this image manually, or perhaps in the next version, we'll automate several of these image-based grading. And as the first step of interventions, we are actually showing the icons as in motion, the animations, which are customized to that house and to that particular individual in real time. So that's the first step of interventions. The next step of interventions is basically giving the person the medicine that is required, prophylactic medicines, or any kind of a blood diagnostic that needs to be done. You can draw blood and then collect it in the temperature control boxes. And as I mentioned, wherever the drones two-wheeler cannot go, the drones can be actually sent to collect the blood samples, or it can be used as a middle mile logistic solution to send the medicines or perhaps the diagnostic samples to a facility that is actually far away. So this is a comprehensive model that we are actually proposing. And in different modules, we are also trialing it in the field for the last 6 months to perhaps a year. So in comparison to the existing devices, the platform that we are proposing are a lot more comprehensive, as in it is not focused at one single diseases, but basically looking at the entire disease condition from all the way to conception to elderly care. And it is also not specific to one particular location. And it is also not dependent on the skill levels of the healthcare worker on the ground, because we are actually using icons and images, which basically seems to be much easier to train the person, and also a lot more reliable, because each of these images are geotagged and a date and time stamped, so that the information that is coming in is actually a lot more reliable and comprehensive. So in comparison to the existing solutions, what we are actually looking at is a home-based care. So that actually gives us an opportunity to provide universal care. The next advantage that we are proposing is a continuous and a dynamic solution. So we are hoping to go to each and every person's home, irrespective of the fact that he or she is sick or not, or deceased or not, and provide health promotion messages if the person is not deceased. If the person is deceased, we'll have to increase the frequency of the visits and then provide very specific care. So this platform is designed for continuous and dynamic care instead of being episodical at the moment. And also, This platform is designed to be much more holistic because we are looking not only at the person as in a deceased person, but also the ability of the person, the nutrition aspect of the person, the water sanitation and hygiene, and also the socio-demographics. So this is a much more holistic platform that we are proposing. And as we go forward, we'll be kind of testing each and every module and integrating it to the existing service. So some of the progress that we have achieved so far is that the healthcare software itself has been fairly developed, and we have rolled out at least 200 examples on the field, and each device or each mobile phone that we have rolled out on the field is being used to screen almost 5,000 people. So we are actually screening more than 500,000 people on the field now. And this is actually being used by the healthcare workers with very little training, very little as in comparison to paper-based questionnaires or in comparison to the existing analog-based services. Instead of training for a week, we are able to train the healthcare workers in 2 to 3 days. That's actually a 50% reduction in the time required for training. But they're also highly reliable because we are actually collecting images which are date and time stamped. So compared to the existing analog system, the services or the screening that is actually being done is highly reliable. And we are also showing all these videos in a very customized way to that particular household, which is very well received by the members of the household. And they are also finding it very useful to kind of manage the disease and also manage the situation in and around the house. So the field trials are currently being done in Nirmal in Telangana, which is in India, Samastipur in Bihar, which is fairly a very large field trial with almost 350,000 people, and in a slightly smaller way with only 100,000 people in Lalgad in Nepal. We are also trying to develop much more comprehensive devices, as I mentioned, to screen several conditions at once. We are trying to come out with devices that not just has a camera as it is being used now in a mobile phone, but the device will have multiple cameras, including thermal cameras, including spectral cameras, and devices that can take much better information and reduce the noise at the point of need. So these are devices that we are actually kind of developing so that we will be able to put it into the two-wheelers or perhaps in the drone and then take it to the point of need. As I showed, the two-wheeler itself is an original development that we actually did, and the temperature control boxes, as you see here in the images, the same box can actually be used for multiple purposes. And we have also made a lot of innovations in the box so that it can protect the payload from vibrations, from temperatures, and also from several issues that are happening on the road. So you see here a complete package where the same box can actually be used to transport vaccines, can be used to transport medical devices, can be used to transport medicines, and also be used to collect blood or any other sample and then taken to the healthcare facility. So it's not only software-based screening, but also we have tried to integrate the products that are actually necessary to manage healthcare situations. If we look a bit closer into the box, you see that there are actually 3 layers. The blue one is the temperature control layer, and we are using phase change material. Again, this is fairly a proven technology. So if you are able to change this blue layer into another layer, we'll be able to vary the temperature that is actually being controlled. So on the far left corner, we have also come out with a two-wheeler that can be used in urban situations, and the petrol-powered one can be used in rural situations. So this is also going to be trialed very soon in the next 1 or 2 months, where we will be looking at urban population, perhaps like the high concentration urban slums that we have in several places, and we'll be trying to provide comprehensive healthcare at home to a fairly concentrated location. These were the initial images of the drones that we actually developed, but then in the video, we do have a working prototype and it's actually shown in the video. So the uniqueness of this drone is this is particularly developed for healthcare requirements. And one of the healthcare requirements is the temperature control. So we are able to accommodate at least 4 boxes, which can carry substantial payload for the services of healthcare. So if you'd want to take this drone to a village or perhaps to a smaller healthcare facility, we will be able to supply all whatever is required by the healthcare facility, whether it is blood or whether it is vaccines, or perhaps like whether it can act as a middle mile logistic solution to ferry all the blood samples that are collected to the larger facility where a lot of analysis can be done. So this is a drone that is particularly developed for healthcare situation, and this is actually a long-range drone. It's been tested only for 20 minutes, but we are planning to expand the range all the way to 200 kilometers and carry a payload of at least 25 kgs initially, but ideally we'd want it to carry almost 50 kgs that will help the primary healthcare center on the field, or a bunch of two-wheelers that are being used on the field as a middle mile logistics solution. So here again, these are some of the close-up images of the drone itself. And as you can see here, it can accommodate at least 4 boxes. And each of these boxes can at least carry maybe 1,000 doses of medicines or 36 blood samples. And if you can multiply that by 4, we are looking at 4,000 doses of medications, or perhaps like maybe even 100 or 150 blood samples. So the bottom screen on the left side gives a kind of an overline representation of the larger class of drones that we are planning to build. And hopefully in the next 1 or 2 years, we should be able to again have a prototype of a drone that can carry 50 kgs and perhaps even travel 200 kilometers. So this is an image of the prototype being inaugurated, or perhaps like shown to the audience by our Honorable Minister of Civil Aviation, and some images of the drone in flight. So as I mentioned, the software is actually being designed to screen all the disease conditions and not necessarily only a few particular diseases. So here we are giving the list of all the disease conditions that we can actually screen. And these are classified into 5 verticals. One is the disease. And initially we are looking at screening for preventive purposes, but as we go forward, we will be able to screen specialized conditions also, but that would also require specialized screening devices, which is where we are trying to integrate several screening devices into our platform. So if we are able to do that, then we'll be able to not only prevent, but also provide personalized management for several disease conditions. But as I mentioned, we are also looking at the disability or the ability of the individual so that we can customize the interventions to that particular person's ability. And also his nutrition status, because most disease conditions are also mediated by immunity status or nutrition status. And we need to make sure that the interventions that we provide are acceptable to that person with regard to the nutrition. And also we need to look at water sanitation hygiene in and around the house, because again, several communicable diseases basically are mediated by the vectors which are dependent on the water sanitation condition in and around the house. So they also need to be addressed. And finally, the socio-demographics and economics. The interventions that medical interventions that we are going to provide the patient is dependent on his education status, occupation status, and his location. And these all need to be factored in and perhaps done automatically, so that the interventions that we are proposing can be used by this patient in a much better way. So as I mentioned, we are looking at not just a disease, but the entire kind of life course of the disease, all the way from pregnancy risk assessment to elderly care and all the diseases that are actually in between. So we are looking at screening maybe the top 10 or perhaps the top 20 conditions of these diseases, and providing the necessary interventions that are actually required at the person's doorstep itself. So as you see here on the input side, we have the image-based or the icon-based screening modules, and the intervention side we have the two-wheeler and the drone platform. But we are also planning to make it mobile by using a kind of a semi-truck that can be used to serve multiple locations in the same time. Several of these innovations have been patented. We have applied for almost 20 design patents, and recently we have also been awarded a few patents. So as we go forward, we are planning a trial with almost 1 million people. And as I said, one two-wheeler platform can basically address the needs of 5,000 people or individuals or 1,000 households. So basically we are looking at rolling out almost 200 modules on the field, so that we'll be able to screen 1 million people. And 1 million actually looks like a large number, but if we consider the fact that there are several diseases, and if you look at it disease-wise, it's only going to be few tens or perhaps even hundreds. And even if you look at, like, let's say births, we are looking at only 20 births in a population of 1,000, and this 20 births actually happen in 12 months. So we are only looking at maybe 1 to 2 births in a location in perhaps like in 1 month. So this million might look actually like a large number, but if you look at it disease wise and condition wise, these will all be in perhaps like hundreds or even thousands at the max. So this is what we are hoping to do in the next perhaps like few years, or maybe in a few months. And the customers that who will actually benefit from this platform is primarily the government health systems, because in developing countries and in countries like India, private care is more available in the tertiary and the secondary level. But with regard to primary care, it's primarily the government or very small hospitals and even trained healthcare workers who actually provide the service. So the governments can actually benefit from such a system where they have invested in an existing system that does not work in a very well way. And if we can replace this with our proposed system, that would actually make it a lot more effective. And there are several hospitals who currently provide, as I mentioned, tertiary care, but would also want to provide primary healthcare in a much more packaged platform. And that is what we are actually proposing. And again, in a country like India, there are several large corporate health systems, especially the ones that perhaps like do business in mining or perhaps like in industries, where they do take care of the healthcare needs of people around them, which also includes hundreds of villages or perhaps even a small town. So these are situations where our platform could actually be rolled out. And non-governmental organizations like USAID or perhaps JICA could also find use with such systems, where again in the previous presentation, they are keen to support the health systems of government, especially in rural and remote conditions. So we are also proposing this platform to larger institutions like USAID and JICA, and some of them have actually shown some support. And the other customer that who could actually find this as a use case is the emerging digital service providers, especially on the healthcare side, where there are a lot of emerging companies who are doing home deliveries of medications, who are doing home collections of blood samples, where the platforms like our two-wheelers and also the drones could actually find fairly widespread use. And as soon as we actually do the screening, collection, we could also do a mini screening if there is any other risks that are actually available with our software platform. So these are some of the customers that we are hoping to target. And as soon as we do a trial, we'll be able to kind of attract these customers and probably scale up the service itself. With regard to the risks and mitigation, this is still a concept. As I mentioned, in certain parts or modules of the concept are actually being used in the field. And the kind of response that we have got is, number one, the products are actually usable by the healthcare workers, but we also need to kind of look for further deeper trials, especially comprehensive trials, where our software and the hardware platforms are kind of screened, or not screened, but actually trialed on the field together, so that we'll be able to get a much better data set. So these are some of the areas that we are actually looking at. The other platform.
Dr. Suresh, just wait a second.
Yes, please.
Dr. Suresh, can you hear me?
Yes, can hear.
Your voice is disconnected. Dr.
Sorry,
Suresh, can you hear me?
yes, I can hear you, Professor.
Okay,
can you hear?
so 1 minute back, because your voice is disconnected. So please, 30 seconds before. Please.
Okay, just give me a second. Am I audible now, please?
Okay, risk of mitigation and the technical risk. So please restart.
Yes, thank you. So with regard to the risks and mitigation, yes, there are several technical risks and market risks and the funding risks with the concept that I am proposing. But in some ways, there is also mitigation opportunities. One thing that we all seem to agree is that the software and the hardware has to work together so that primary care can actually be provided. And also, if it has to be primary care at the home, a comprehensive solution has to be proposed, and the concept that we are proposing is fairly comprehensive. But the challenge here is to run a large scale and a comprehensive field trial where the software and the hardware is actually tested together. At the moment, we are only looking at testing individually. Again, these are because of funding challenges. With regard to market risk, we are also looking basically at services that are being delivered vertically, and what we are proposing is a horizontal service. So again, this is fairly fundamentally a new idea that we are trying to kind of propose. And with more evidence that is actually coming in, especially from the software, people are more and more acceptable to this service or probably to the concept, and we are actually finding some interest with regard to the larger players also. And again, there are some funding risks, which because this concept again has multiple modules, and some people are interested in certain modules, but we'll have to find some person or a donor who can actually be interested in all the modules so that we'll be able to get comprehensive data to support this idea also. So these are some of the challenges and basically the mitigation that we are actually offering. And this is one of the concepts that, or rather one of the concepts that have been actually spun off into a separate company. The first company, startup company of Public Health Foundation of India. So this is actually being floated by some of my students who have been working in this concept for a fairly long time, and also by me. And as we go forward onto the business side of it, it's also been very challenging because most of us actually come from the technical side, the healthcare side, and coming out with a business proposal and finding a business way forward plan is a little bit of a challenge. And that is where we are actually seeking some support, and also Professor Anegawa's effort to kind of give this as a platform to present and get some experience or comments from you is actually one of the objectives of this session. But looking back, this is actually a solution that's been developed for a very long time. And as Professor Anegawa mentioned, I've been part of this grant design program from almost 2010, and incrementally has been actually presenting several advances or several innovations that we have done. But now looking back, it looks like a comprehensive program. So it's been in development since almost 2008 and 2010 actually. So it's been long in the development. We are hoping to work on this for the next 5 to 10 years. But with your support and comment, I believe we'll be able to go forward a lot. Thank you for listening to the presentation, and I'll be able to answer any questions or comments, please.
Okay, thank you very much. And Dr. Sasahara, is it better to have your comments in Japanese right now or sometime later?
私は後で。
Okay, so at this moment, please raise question to Dr. Suresh, and comments and questions are welcome. Any volunteer? Okay, so before the question, that you may have the team member right now here. Dr. Suresh, do you have a team member here?
Yes, some of my team members are here, I guess.
Is there anyone who wish to speak and add something to your presentation?
Let me just quickly ask, would you like to add anything to the presentation? Ms. Priya, Nikita, I think Ms. Bhavya and Hamda are also there. I guess no, for now, I guess.
Okay, I understand. So your presentation might be very comprehensive, and it reflects more than 10 years your experience. And so my question is, what is your most important part at this moment? What you are doing and what are you solving at this moment? So I believe you finished everything as an experiment to manufacture and design the device and the system. And this may be your second phase of your project to have the implementation or experiment, the large-scale experiment. You mentioned the 1 million people. So I believe this might be the second stage of your total project. Is that correct?
Yes, and yes, Professor, but there is also an intermediate step that we need to consider. The concepts that I actually shown are all lab-based concepts. They are not service ready. If you can see the handheld device, it's fairly an assembly of components. It's very challenging to come out with a full-fledged device in India. The two-wheeler platform also has temperature control boxes, but there are requirements for IoT devices where within the box itself, we need to measure the temperature. Within the box itself, we need to see if there are any devices that can be attached for measuring vibration and also tracking the locations. And the software itself is now focusing on a few diseases, but it needs to be expanded to different use cases also. So there is a development part also that we need to accelerate. And one of the suggestions or one of the thought processes is if there is a possibility of setting up a startup company in Japan also, so that we can fast track the development of the products. The drones also, we have kind of come out with a concept, but to kind of extend the range, and India is a very big country. So if we need to extend the range to 200 kilometers, or perhaps even build control systems that we can actually fly the drones with 25 kgs or 50 kgs, if we can join with a Japanese company, or perhaps again, if we are setting up a startup company in Japan and then doing the development, that would actually be very helpful. The next part, as you said, is we need to run a large trial or a large pilot. And again, the number of 1 million is a hypothetical number. We would be happy to even start with a pilot with 100,000 people, or perhaps like even a much smaller number, as in 50,000 people also. So this is where we are looking at support from organizations like JICA to see if we can actually run a trial in India, or perhaps in one of the neighboring countries where they could be actually interested in, again, like Thailand or Bhutan, or perhaps any other place where they already have a very good working relationship. So these are the two areas that we are looking on. One is further development of the technologies to make it into service ready rather than being a concept, and subsequently a field trial where we can test them all together.
Okay, so you say many things at the same time, but first example is a drone or startup to establish the joint work with a Japanese corporation.
Yes, Professor. I think the product side of it, the drone and the handheld device, because both of them, it's very difficult to find components in India. If it be possible to work with a Japanese company or establish a startup company in Japan, I guess that would be a very good way forward.
Okay, that may be the two present issues. And the part one, Melody International, they are specialists to make device, and they also use the drone. And is there any suggestion from the Japanese side, Melody International, and Professor Hara? So that might be that kind of the suggestion might be needed. So also there might be the suggestion from the Dr. Sasahara. What kind of the cooperation between India and Japan might be available? So that is my question to the audience. Any comments? Okay, Ninomiya, please start.
Thank you for a very impressive presentation, Dr. Suresh. So, yes, this is not a suggestion. We are still producing the medical device, but we like to aim to spread the device more, a lot of people. So, but it's still, very, the device cost is still high, and only the, medical facility can afford to buy. So we'd like to, reduce the cost of the device, and it need to be, more bigger population and bigger market. So probably it is going to be, it will be in the India market. So someday, yes, maybe we'd like to cooperate with the people with India, probably with you, and make more device and reduce the price, cost of the device, and then implement device more people rather than the hospital.
Okay.
Thank you.
Go back to the Dr. Suresh. Your experiment might be start from the population of the 1 million or so in one specific state. How many handset device might be required, and how many drones are required? Because Mr. Ninomiya claimed some kind of the scale up or scale economy might be required to reduce the cost.
Yes, that's right, Professor. I mean, the population ratio that we are looking at is 1 two-wheeler per 5,000 people. So if you are looking at 1 million people, it will be 200 two-wheelers. And we are looking at 1 drone per 10 two-wheelers. So if it is 200 two-wheelers, there is a requirement for at least 20 drones at the ratio of 1 drone per 10 two-wheelers. So 200 handheld devices, 200 two-wheeler platforms, and then 20 drones is what we are hoping to. I mean, these are hypothetical numbers.
Okay, this might be the initial stage, and that number, still the price might be very high when you first develop that kind of the device. What is your opinion, Mr. Ninomiya?
Yes, yes. I just imagined in India, so many population in there. So and so so many technology in India, so that all the device can be cost of the device can be reduced, and in Japan, it's not so many population, especially in the pregnancy. So Indian market is more suitable for using the cost of the device.
Eventually, the Indian population, potential population is very huge. So eventually, the cost might be reduced significantly. But the initial stage, they need some kind of money to develop the initial 200 device or 200 drones. So that might be the one concern. Second concern might be the Dr. Suresh mentioned some key part of the device or drones are not available inside India. So for that purpose, you need to establish the startup between India and Japan. Is that correct, Dr. Suresh?
Yes, that's right, Professor.
And I believe that India's corporation, your project may have the tie with Chinese and other countries, European corporations and the Chinese corporations, not specifically with Japanese corporations. Why do you need Japanese tie-up?
Well, as of now, working with Chinese is very difficult, and Indian government really does not encourage working with the Chinese government or Chinese companies. So current geopolitics is fairly against China. That is number one. The second is Japan has historically has an advantage with regard to the production of sensors. A lot of original sensors, even in like Apple iPhone, a lot of the actual sensors are from Japan or Sony. So historically, there is an advantage, and there is a edge that Japanese companies actually have. And also, Japan presents a very concentrated source of these technologies, whereas if you're looking at Europe or America, maybe the same sensors are available, but we'll have only certain things in certain countries or certain states in America. And some of them are in the East Coast, some of them are in the West Coast, whereas in Japan, if we consider Tokyo, from Tokyo to 3 hours travel by bullet train, you will be able to find literally all the requirements that we actually need. So this is a much more concentrated location, and also a fairly good location for advanced technology. So it's much easier in a logistical way to kind of have a base in Japan and then work with. With regard to the cost, if we compare the fact that we'll have to do everything at least 3 times, 5 times, or 10 times in India to achieve the same levels, compared to the fact that 1 or 2 iterations in Japan would achieve the same results. So realistically speaking, working in Japan would actually be cost effective rather than working in India, or perhaps like even working in America, where the cost of human resources, unfortunately, is a bit more expensive compared to Japan. So either way, whenever we look at for the products, I think Japan is actually a very cost-effective location because of the availability of the sensors and the components in a very concentrated area. And also the turnover time could be very fast. And also the availability of skill levels is very high with regard to technologies. I mean, in other areas, software is good, but hardware and software combination is very good in Japan.
Okay. And additional question is, you wish to create a new corporation, joint corporations between India and Japan to develop the handset and the drones, correct?
Yes, that's right, Professor. I mean, initially it can be an independent entity, because even Japanese government is now supporting startups by foreigners. I think there is a separate Japanese program also, and there are designated locations within the country where foreigners can actually start up a company fairly very quickly. So we would like to take advantage of that and then initially set up a startup entity, and depending on the progress, whether we can tie up with the existing Japanese company or connect with the Indian company, I think that can be decided as we go forward.
Okay. Any other comments from the audience? No one?
I have one comment. I mean, although setting up a company is actually advantageous and also possible with government support, language is still a challenge, where a lot of communication within Japan is actually in Japanese and not much in English.
Oh.
So that is where I think if we can possibly find some partners, or perhaps like if people would also understand the work that we are doing, and if they can work with us, I think that will be really very helpful to go forward.
For example, this is the NUCB Business School, and previously your project is located at the University Business Schools. And so the business school graduate or that kind of the people, do you need?
Yes, that's right, Professor. People who are very fluent in English and in Japanese, if we can find some support, or if they can actually work with us, that would be really helpful.
Okay, requirement is the Japanese and English and the business knowledge and networking. So that might be exactly the Mr. Ninomiya. She might be the idealistic person with combining all knowledge and abilities. Any further comments? Professor Uchino is there?
Yes, I'm here still.
Any comments on his project?
Let's see. Suresh, you're not thinking to collaborate with the US.
Professor,
Actually, you may not know me. I used to be a Pennsylvania State University professor, and I'm also the Navy Office of Naval Research Officer, Program Officer. And I was working in Japan for the Asian division of the Navy. And I distributed research funds and also collaborative work with the United States. And also at that time, that was 2010, compared to the prior period, the US and the Japanese, the US and the Indian Navy collaborative work started. Therefore, I visited a lot of Indian universities and institutes to collaborate with the US. Of course, our Navy is interested in medical and also the defense, both the weapon and so on. But of course, I am not sure the Navy is interested in to support the typical public medical support. We are interested in high technology like a Navy related. So regarding remote and so on, we almost established and also teleoperation system. So the medical doctor in the United States can operate the soldier in Afghanistan or other places remotely, okay? That really worked, and I helped to make some collaborations. But of course, some of the small business, the Navy is also supporting some of the business. When I was a Navy officer, I already retired many years ago, but 2010 till 2014, you remember the big earthquake in Japan. So yes. I supported multiple small business who are working for the critical technologies, such as how to monitor the nuclear power plant radiation and so on. Because Japan is a kind of robotic, some countries, but unfortunately they don't have any crisis technology related robots, such as operated in the nuclear power plant. Or drone also was typical like a toy, like they have it. But you may know our Navy's drones, bringing a lot of weapons, everything, 10 kilogram, right? So we worked and a lot of the drones. So I worked with iRobot to bring some of the robotic system in Japan. So that was now very popular even in Japan. So the robotic system, small business in the United States has lots of robotic system. The drones, they are mostly interested in to provide to the US Navy, Army, and so on. But compared with the Japan, these critical drone systems, the US had a small business and providing lots of drones to the world, okay? So that is just an additional comment. Of course, you are seeking a Japanese cooperation, so it's fine. But the Japanese drone system, even the robotic system, is quite expensive. That's another problem, okay? We are expanding the drones, lots of drones daily base in the United States. That is also programmatic situation. Even Amazon.com usually bring a delivery through the drones. They typically in the downtown area, okay? So that kind of relatively reasonable drones, you can easily obtain already from the United States. Of course, the country relationship. You mentioned the India and the China relation. Yes, I can understand. But US is a little hesitating to work with India as a trust partners, because India is now approaching to the Russia. So we don't know the situation, but most of the small business in the US is related with the US government or Navy, Army, military. So I don't know the current situation because already I retired and moved to Japan. And the coming government is still question. If the previous president will become a president, yes, the additional friction between the countries may happen. Therefore, we don't completely recommend the US, but what I would like to say is the US has already all technologies.
Okay, I understand. And Professor Uchino knows many things in the world, so you can ask him about the availability of the technology and devices in the United States or military sector of the US, and he knows much about Japanese enterprises. So you can rely on his information in the future project planning. And
Sure.
Okay.
Sure. Thank you, Professor. I'll follow up with Professor Uchino after this discussion.
Okay. Thank you very much. And any further comments and questions? Okay, thank you very much, Dr. Suresh. And this may be very convincing and very promising project you have. So you will plan the next 5 or 10 years from now to implement everything?
Well, hopefully in a few years, I think, or maybe even in a few months, we should be able to take things forward, Professor. At least in the next 2 to 3 years, it looks very promising to implement all these technologies.
Okay. And we will continue the discussion after your presentation. Thank you very much.
Thank you, Professor.
Thank you.
はい、ちょっとお待ちください。今からレコーディングをいたしますので、では、すべての